from Monza, Italy.
Good afternoon. I'll try to stay finished before 6 o'clock. So, first of all, we expect you to accept the concept that ARDS patients are hypoxic, and they also have a low compliance, because this is the definition of it. And first of all, if a patient is hypoxic, most of the times we refer that to intrapulmonary shunt. But we have to evaluate their PO2 and arterial oxygenation. And first of all, there is a certain uncertainty about whether we can classify the severity of those patients according to PO2 and arterial and PO2 FiO2 ratio. Now, the recent Berlin definition classifies patients according to PO2 FiO2 ratio with different mortality rates. But still, and this was validated in a few thousand patients. But this was known since before the Berlin definition. In this study, as an example, Brambison showed that mortality is related indeed to PO2 FiO2 ratio. However, we should keep in mind that changes in arterial oxygenation or changes in PO2 may be dependent not just on pulmonary gas exchange function. And one of the major issues here is mixed venous saturation, that is cardiac output. If we have a patient with a 50% shunt and 75 mixed venous saturation, with the shunt portion of the venous outlet of the lung will have a 75% saturation by definition, while the ideal sector of the lung will have an outlet of 100%, so the arterial saturation will be 87.5, with a PO2 approximately 58. If we now decrease cardiac output and mixed venous saturation goes to 50, and the anatomical shunt is still 50%, now the mixture becomes now between 100% and 50%, not 100% and 75%. So arterial saturation will now be 75%, and the arterial PO2 will be 40. Arterial saturation has changed accordingly to the change in the mixed venous. And PO2 is very sensitive in this region. So when we evaluate arterial saturation in a patient with an intrapulmonary shunt, the higher the intrapulmonary shunt, the higher the arterial saturation will be dependent on the mixed venous one. We normally use PO2 FiO2 ratio, both to define ARDS and to define the severity of ARDS. However, PO2 FiO2 ratio, as defined, are not constant, and they may vary according to ventilatory settings that you all know. In this study that was performed almost 10 years ago, patients defined as having ARDS underwent a standard ventilatory setting with a tidal volume of 7 to 8 milliliters per kilo, PEEP 10, FiO2 1, for 30 minutes, not 3 days, 30 minutes. And in 30 minutes, a major proportion of those patients got an improvement in PO2 FiO2 ratio that made them go out of the ARDS definition. Moreover, PO2 FiO2 ratio depends on FiO2. Here you see that these patients that in room air has ARDS may very well go to a much higher PO2 FiO2 ratio, simply increasing the FiO2. That is, PO2 FiO2 ratio is not constant when you change FiO2. And strictly speaking, PO2 FiO2 ratio should be defined or should specify at which FiO2 the measurement was taken. The simplest way we have to correct correct PO2 is to increase FiO2. However, we should keep in mind that increasing FiO2 may favor reabsorption atelectasis. We often forget about the possibility of reabsorption atelectasis. At high FiO2s, a lot of oxygen is extracted from the alveoli in presence of very little nitrogen. So the alveoli decrease in volume because the oxygen is brought out by the blood flow. And in this study, which was performed at the time that when people were still doing multiple gas exchange, multiple inert gases evaluation of VAQ ratios, it was shown that even in ARDS, the use of 100% oxygen would increase substantially intrapulmonary shunt, from 16 to 22%, or from 20 to 23%. And the presence of reabsorption atelectasis is possibly related or possibly reversed by the use of PEEP or recruitment maneuvers, as shown by this paper from the group of Goran and Stierna in normal lungs undergoing anesthesia. You see here a patient at induction of anesthesia, FiO2 40%. It has some paravertebral atelectasis, which is reverted by a recruitment maneuver, and the recruitment stays there at 5 minutes and 45 minutes. But at a FiO2 1, first of all, the atelectasis is bigger to start with. It is indeed reversed by the recruitment maneuver, but in 5 minutes is already back, and in 45 minutes is as much as it was there at the start. So we should probably keep in mind that in ARDS we may have reabsorption atelectasis at very high FiO2s, and that the effects of PEEP or the effects of recruitment will be dependent on the FiO2 we are using, saying that the higher the FiO2s, the higher the disappearance of the benefit of recruitment. Now, so much for oxygen. Today, our attention is very much focused on CO2 removal. And we know that the lung in ARDS is small. a small portion of the lung is ventilated. I always show this slide. Sometimes I will stop showing it. But since these are true numbers, it's a very strong argument. A normal subject has 2.5 liters of ventilated alveoli at end expiration. Minute ventilation of a normal subject is normally less than 7 liters. So we have less than 3 liters ventilation per liter of alveoli. If you like, you can think that 1 liter of alveoli is approximately 3 million alveoli. In ARDS, at F4C, zero pressure, the open alveoli may be as little as half a liter, but those patients are often ventilated 13, 15, 16 liters per minute. So each liter of alveoli receives 30 liters of ventilation. Now, if you think about mechanical stress, you might realize how different is the mechanical stress between a normal lung and an ARDS lung. Being ventilated not twice, not 3 times, but 10 times more than the normal lung. So this brought up the concept of a baby lung struggling to keep alive an adult body. Now, why are those ARDS lungs ventilated so much? ARDS is an hypoxic disease. Why should we ventilate them 15 liters per minute? Because obviously we must have a huge alveolar dead space. That is, lung which is ventilated but not perfused. When I was a young man, I thought ARDS is a lung with a lot of perfused and not ventilated regions. It's wrong. We do have indeed perfused and not ventilated regions. But obviously, we must have a lot of ventilated and not perfused regions, that is dead space. And that is, well, it's true, anatomic dead space might be increased. Shunt itself increases dead space. Because if I have a lung, one of my lungs is ventilated but not perfused, all the ventilation goes the other side. And it will not be enough, the ventilation I had before. I have to increase the ventilation because I have to maintain a normal PCO2. If my end tidal is 20 millimeters of mercury, my dead space is 50%. If my end tidal is 13 millimeters of mercury, my dead space is 70%. The reason for the high ventilation, low perfusion regions is most probably microthrombosis. Antoine Vieillard-Baron showed you this same picture. Well, it's not exactly the same picture, but a similar picture with different colors, showing the same phenomenon, pruning of the arterial tree. We have widespread microvascular occlusion and the increase of the muscular layer of the arteriolar tree of the lung. Dr. Vieillard-Baron showed you data that correlated pulmonary artery pressure to mortality. The higher the pulmonary artery pressure, the higher the mortality. Pulmonary artery pressure comes from the fact that we have occluded vessels. Occluded vessels means increased dead space. This is the same slide with dead space instead of pulmonary artery pressure. The higher the dead space, the higher the mortality. So ARDS is not just an hypoxic disease, it's a pulmonary microvascular disease. And we have to keep in mind that being a pulmonary microvascular disease, we have pulmonary hypertension and hypertension on the right side of the circulation, which might open up right to left shunts, which may be one of the causes of hypoxia. And the Dr. Meconso de Sapp, working in the group of Laurent Brochard, showed that in 15 to 20% of ARDS patients, we not only have pulmonary hypertension, but we also have intrapulmonary shunt. And paradoxically, if you increase PEEP to correct your low PO2, the shunt increases and PO2 does not change. So the recommendation is to check when you see an unexplained hypoxia, to check whether you don't have an intrapulmonary shunt. And so your normal maneuvers of increasing airway pressures and increasing PEEP will not correct the hypoxia, and sometimes it might make it worse. Last comment about PCO2. We have seen quite a bit of papers correlating decreases in PCO2 to effective recruitment. So it's true. There are even papers and works showing the minimization of dead space as a way of selecting best PEEP. The idea here is that when we want to achieve the best recruitment of the lung, but the good recruitment is the recruitment of perfused alveoli. If you recruit alveoli which are not perfused, the VAQ distribution will, as a matter of fact, get worse than it was before. So if we do a good recruitment, we have good reasons to think that this should be followed by a small 1, 2, 3 millimeters of mercury decrease in PCO2, altogether with an increase in PO2. While if we recruit dead space, that will affect negatively the the CO2 removal or leave it at the same level. So I think I've reached my conclusion. So when you evaluate PO2s, keep hemodynamics in mind. Changes in hemodynamics are as important as changes in lung function in determining PO2, particularly if the lung of your patient has a high shunt. The higher the shunt, the higher the effect of the changes in hemodynamics. Second, carbon dioxide elimination is a major problem in ARDS, and dead space is a major problem. And as a matter of fact, the difficulties in eliminating CO2 are the main cause of ventilator-induced lung injury, because that is the reason why we ventilate so much these patients. Thank you very much.
Thank you, Antonio. Some questions or comments before we close? Maybe just in your clinical practice, do you ever measure dead space in your patients?
I always measured end-tidal. Measuring dead space requires a volumetric integration of a continuous CO2 reading. And as a matter of fact, we have to have either a specific ventilator or a specific monitor to do that.
Martin has a question.
Well, Antonio, very nice presentation. Just on your last point, you said that the main problem in ARDS is CO2 elimination, and that's why we cause ventilator-induced lung injury. Obviously, the corollary...
Well, it's a bit paradoxical, you know.
Right, but the corollary of that is then if we had ways of eliminating CO2 that did not require mechanical ventilation, such as extracorporeal CO2 removal, that this should markedly change outcome in these patients, and it doesn't, right? No?
We have no strong data for that,
Okay.
but we have good ideas about it. So
All right.
the hope, we must be left with hope.
Thank you. So we'll close this session with hope for everybody. Thank you very much.